Hello and welcome to this AO Trauma Hand online series, the Three Cases Fireside series. Our task was to discuss compression neuropathies, and we had the opportunity to involve Lee Osterman. And as we want to take advantage of a lifetime of his taking care of really complex things, we decided to change our topic a little bit and really focus on failures in compression neuropathy. So Marco Rizzo is the chair of our hand education committee and really started this three case based series where we'll look at it from multiple facets. Again, our sage tonight, Lee Osterman, is going to share his career's experience with this from the Philadelphia Hand to Shoulder Center. I'm Jeff Lawton. I'm going to be the moderator. I'm from the University of Michigan. Our faculty, Kate Hinchcliff, coming to us from University of California, San Diego. Again, Dr. Osterman, and then Porretto-Loehrke from Appleton, Wisconsin. The disclosures have all been mitigated. Here you see the relevant disclosures. None of them impact tonight's discussion. Again, for many of you are familiar, but for those of you not, AO North America is an independent, non-profit surgical specialty society dedicated to education and improving care of patients with musculoskeletal mitigated conditions. Here you see the relevant. The goal of this talk isn't to endorse or promote the use of any product or service, but really education and concepts. And none of the things being discussed are demonstration for that, just for education purposes. For those of you in North America interested in CME credit, as you know, this is a series of lectures, and at the end of the series, there will be a CME available. In terms of Zoom, all of your microphones and cameras have been turned off, but we certainly want to invite interaction. So please, if there's any questions that come up, please send them through the QA function. The moderators will review them. Some of them will answer directly, and depending on our timing, some of them will pose to our appropriate faculty and speakers. And then the chat we use for our internal communication to try to have things run seamlessly for you guys. So again, we're going to base this on three cases. I'm going to present a case on failed carpal tunnel release. Dr. Osterman's going to reflect on his experience with failed carpal tunnel. And then Kate Hinchcliff's going to talk about failed cubital tunnel. And then Porretto-Loehrke, who's a hand therapist, is going to give us some pearls in therapy on compressive neuropathy. And then we will have time for a little bit of Q&A. So our objectives for these talks in general, we want to think about indications for the surgical procedures being discussed. Identify and understand the clinical criteria required for these procedures, their indications, talk about the surgical anatomy and surgical steps in appropriately executing these procedures, discuss some of the possible pitfalls and strategies to avoid them, and then a discussion of the pertinent literature. Just to let you know of some other offerings, some other upcoming webinars in February and May, looking at phalangeal fractures and complex distal radius fractures, and then other online things in the spring. January, Hill Hastings talking about PIP fracture dislocations, Jinbo Tang talking about flexor tendon injuries, and Amy Ladd talking about distal radius fractures. A few in-person courses. February in Jacksonville, Florida is a regional one-day hand and wrist fracture management. And then one of our comprehensive courses, Fellows and Chief Residents course at the J&J Center in Cincinnati, preparing for fellowship and beyond. Many of you know we have a channel on YouTube, and tonight's webinar will be up in about 24 hours on YouTube. And then we're also on OrthoTV online. So again, I want to welcome everyone to this presentation, and I'm going to start presenting some concepts in a case on failed carpal tunnel release. So our objectives in this talk are to help you develop a method to critically evaluate failures of carpal tunnel release, both in your own patients and in a referral practice. Give you a little bit of a basis of an algorithm to determine treatment, and then we're going to focus on specific surgical treatment for failed carpal tunnel. So what's the scope of this problem? Typical hand surgeon, if you do 2 to 3 carpal tunnels a week, about 50 weeks a year, just to make nice round numbers. So that's about 100 carpal tunnels a year that you would primarily perform. We know it's one of the most successful procedures we do, but still multiply quoted as about a 5% failure rate. So that means about 5 patients of yours per year, plus, figure 2 to 3 patients from other practices in your community as second opinions, 25 plus years of practice. So that's 150 plus patients you're going to see over the course of your practice lifetime. We can talk about polycizations or distal radius osteotomies or other kinds of, really cool and interesting things. But quite honestly, failed carpal tunnels numerically are going to far exceed those. So having a way to assess them and sort of have an algorithm and an approach to them is really important. So I want to define some terms. So failure, when we're talking about failure of these and throughout these talks, we're talking about failure as no relief of symptoms, and then partial failure, meaning they have some improvement, but they still have some persistent and significant symptoms. And that might be someone who goes from being completely numb to now they're hypersensitive. So they can have a partial failure. And we want to distinguish this from recurrence, meaning they did well and then 7 years later they get symptoms back. That's really not what we're talking about in most of this talk. So Susan McKinnon looked at about 100 carpal tunnel releases in about 87 patients and found persistent carpal tunnel, meaning some continued symptoms, in 42, so almost half, recurrent in 19, and new symptoms in 36. And by new, meaning symptoms that did not exist before, and these tended to be incidences of nerve injury. So what she found is incomplete release of the flexor retinaculum and scarring of the median nerve were common findings overall. The recurrent group most commonly was associated with diabetes, and as one might imagine, the longer interval from the carpal tunnel release, the greater the likelihood of having recurrence. And these patients didn't really have pain as much. Again, nerve injury of some kind was more common in the new symptoms group. And carpal tunnel release, unfortunately, was found not to always be entirely successful. Obviously, most of these improved with some type of revision, but again, stressed a methodological approach to diagnosis and adherence to some surgical principles. So, when you see these patients, they come to your office and I had a carpal tunnel release and I'm no better. With them might be their upset spouse, perhaps a workers' comp nurse. Maybe they have a stack of papers that, quote, you need to fill out. So it's good in these situations to sort of take a step back, maybe take a breath and say, okay, what were your symptoms before surgery? What are your current symptoms? Assess how they changed. Take a look at their incision. Does it look like a carpal tunnel release incision? And then again, depending on your community and your immediate practice environment, think about special case for failed endoscopic carpal tunnel release, and that might be a subject that we can discuss amongst our SAGE. So if they come in with an incision over here, but the carpal tunnel is over here, it's pretty straightforward that, maybe just doing a carpal tunnel release will get them some relief. So some of the things you may want to look at are a pre-op EMG, perhaps repeating an EMG, see if it's the same or worse. And then think about in your environment what the role for ultrasound is. Is there a role for post-op ultrasound? And again, another thing that we can discuss is, do we have enough experience to compare pre-op and post-op ultrasound the way we do with EMG? So this one study that I want to share with you, looking at ultrasonography findings compared to intra-op findings, They looked at high resolution ultrasound and then were able to compare it with surgery in 35 nerves. And in the case of failed carpal tunnel, not surprisingly, they found persistent compression in 30 of those 35 patients. 20 patients had compression due to residual transverse carpal ligament. 4 had perineural fibrosis, and 5 more had both. 1 had tenosynovitis. 4 of those patients had evidence of some type of median nerve, either epineurial or fascicular injury. 1 of those patients, they found nothing. And their conclusion was that there was a good correlation between ultrasound and surgical findings. Interestingly, 1 of the patients had a giant cell tumor, which was missed on ultrasound, which is sort of surprising because I would have thought ultrasound would be good at picking that up. But so I wanted to look at a patient, a 59-year-old patient of mine who underwent a carpal tunnel release for electrodiagnostically severe right carpal tunnel syndrome. At 2 weeks, he came back and said his numbness and tingling was gone. However, now he complained of what he called zings of sensation into his fingers with heavy hand use. And this is not an uncommon finding in, middle-aged or older patients with electrodiagnostically severe carpal tunnel. So I sort of, wanted to observe it. And then he came back at 3 months and really said he'd plateaued, no further improvement. So we did have a pre-op EMG, so repeated that, and it actually looked a little worse. His median motor latency actually increased a little bit, continued to have needle changes. In the interim, he had undergone bilateral total knees, and with the use of crutches and a walker associated with that, now his symptoms actually got worse and his numbness had returned. So again, just defining our terms a little bit. This is Fraser Leversledge, JAOS article and some tables from that. Very clearly in patients with persistent carpal tunnel, a redo carpal tunnel release, especially if they have a errant incision. Other than that, some type of revision carpal tunnel. And again, in recurrence or persistence, perhaps something to optimize the environment. So I wanted to introduce everyone to this concept, and this technique was described by the Indiana Hand Group, Strickland, Idler, Gary Lurie, and Kevin Plancher. And as we look at some of these great drawings, so the median nerve and the carpal tunnel in this cross-sectional view is here. And what we're going to take advantage of is this fat in the hypothenar area. And when you're describing this to patients, I always show on myself that we all have fat in the hypothenar area. So you have to be careful that you're not calling your patient fat. But there's a little dollop of fat that we all have there that we can take advantage of. And it's based on this ulnar neurovascular bundle. So they did not come up with this concept. This was actually Methuen. But his concept was actually to dissect and mobilize the pedicle with it, as you see here, versus their technique of actually maintaining the pedicle in place and just mobilizing the fat. So for their article, they did do some anatomic dissections, as you see here, and you see the fingers would be towards the bottom of the page and the elbow would be towards the top of the page, and you see the ulnar artery, and you see segmental perforators going to that pedicled hypothenar fat flap. So this is a cadaveric dissection that we did. So the blue line is sort of where a typical mini open carpal tunnel release would have been, and you can see the dots extending across the wrist. You make your incision through dermis, and then we're going ulnarly, so the thumb is towards the top, and basically raising full thickness skin graft, as you see here in cartoon. And then this is what that pedicled hypothenar fat flap looks like. So you see it's a fairly robust flap. And then we're resecting the recurrent or persistent ulnar leaflet of the transverse carpal ligament, as you see here. Then we're clearing a space on the radial floor of the carpal tunnel. As you see, this Army Navy is retracting the floor of the carpal tunnel. and then bringing that pedicled hypothenar fat flap down to the radial floor of the carpal tunnel, as you see here in the pictures, and then insetting it, and then suturing it in place, again, as you see here in this cross-sectional picture. And this is a video that one of our residents put together.
Starts the preparation of our flap and allows us to elongate the flap for less tension at the ends. Taking care of targets for our anchoring sutures. Your anchoring sutures tied, that flap is next. Lastly, we
So that was a real nice video that Lauren Swaney did, and you can see that gives you a nice, robust envelope of fat around the nerve. So that's what we did in this 59-year-old. He had this revision carpal tunnel release with pedicled hypothenar fat flap. And again, as you see here, skin incision. Here's our fat flap mobilized. And again, it's a fairly robust environment that we're going to put the nerve in. You can see this nice envelope of fat. Here you can see it inset in this patient. And then here he is at 2.5 months. He notes that his numbness and tingling is gone. He went snowmobiling, which is pretty excessive use of the hands and significant vibration, and noted no numbness. So again, I want to leave you with a take-home message of developing an algorithmic approach to failed carpal tunnel releases, because you will see your own and you will see them from the community. And it's really important to determine, will the patient benefit from another surgery? Obviously, if it's pure recurrence, pretty obvious that a redo carpal tunnel release is sufficient and very predictable. However, in a sort of a failed, incomplete release or persistent symptoms, some type of extended carpal tunnel release with an environmental improvement, I've been very happy with in my practice. So thank you. I will turn it over to Lee Osterman. Dr. Osterman, as you know, has a long career of taking care of complex things such as this, and we'll invite Lee to share his experience on how he takes care of failed carpal tunnel release.
Good evening, all, and honored to be considered a sage, particularly with this group. So hopefully I can offer some useful information that will give you some take-home points. Well, as Jeff pointed out, we really are in the age of carpal tunnel syndrome. Remember, carpal tunnel is only a diagnosis really since 1946, post-World War II. Prior to that, everybody had thoracic outlet syndrome. And now people all have carpal tunnel syndrome. In fact, we've seen it go the other way. When someone has, for example, a pronator syndrome or brachial plexus, it's often missed because everybody assumes that everything is carpal tunnel syndrome in this relative epidemic. And in our country, they do about 250,000 per year. And as you all know, there are a number of ways to do, from a standard palmar to a mini to an endoscopic to an extended. And if you're doing carpal tunnel surgery, you should, I think, have familiarity with how to do each of these techniques, because I think there are roles for each of them. For example, in someone who's having a revision, you may need to do an extended technique. In someone who has an abnormality or a schwannoma in the nerve, things that may require a more extensive technique. And then many patients may benefit from an endoscopic or a mini, which I think are pretty much equivalent, and sometimes a transpalmar. So you should be familiar with each technique. And regardless of the technique, we generally consider it a relatively simple, safe, and a successful procedure. In fact, the Cochrane data suggests it's the only proven treatment for moderate and severe carpal tunnel syndrome. It affects about 10% of the American population at some stage in their life. There's an old Irish proverb that may you live long enough to have carpal tunnel overall. And as pointed out, the classic carpal tunnel has the median nerve and 9 flexor tendons, but often there can be other structures which can intervene in the process. The success rates, if you look at all the literature, are usually in the 90% range, but 2 to 25%, depending on the literature, have either improved symptoms, persistent symptoms, or recurrent symptoms. In one paper listed here, looking at the epidemiology of carpal tunnel revision over a 1-year period, using basically the diver statistics, in almost 4,500 patients, they found that about 4.8 underwent a revision within 1 year. One of the lessons from that was it was a little bit higher if the person had primary endoscopic carpal tunnel in terms of revision, partly because not everybody does endoscopic, and if somebody did endoscopic and goes to someone who believes that you should do open, he's more likely going to say, well, they probably didn't release it all, and that may not be true. Other factors which increase revision rates are diabetes, tobacco use, some psychiatric conditions, double crush with cervical disease plays a role, and associated cubital tunnel seems to have an incidence of. In terms of the revision surgery when it's done, this is a study from France looking at 40 cases with a 4-year follow-up, so a decent follow-up. You can see that about 75% had excellent to good results from the revision, and about a third had fair to poor results. that risk of those poor results was significantly higher in the presence of intraneural fibrosis, if they had a severe sensory deficit, if they had a neuroma of the palmar-cutaneous branch, if there was an associated workers' compensation, and more importantly, if they had multiple previous surgeries, and that seemed to have the best correlation. So carpal tunnel is not something you can operate on once, it doesn't work again. It's sort of, in my book, 3 strikes and you're out. Well, why do things fail? We've heard about incomplete release of the transverse carpal ligament. It's often listed, particularly in those people who believe that endoscopic may not fully release it. Often there's a wrong or incomplete diagnosis. Unfortunately, I see a number of people who've had 2 or 3 carpal tunnel releases, no improvement, but their examination shows that they have a pronator syndrome or they have a more proximal lesion. So it is important, particularly in the patient who's had a persistent or unrelieved symptoms from carpal tunnel, to do a thorough investigation proximally overall. Certainly perineural fibrosis, iatrogenic nerve injury. I'm not really going to talk about. These are carpal tunnels that where there wasn't an iatrogenic nerve injury, but it certainly occurs. In our series of a 10-year follow-up of patients referred for failed carpal tunnel, we had 101 lacerations iatrogenically of the median nerve or partial lacerations of the median nerve. So that's about 10 a year on a referral basis. So it still occurs, but I'm not going to deal with that because those patients present a whole host of difficult problems. Certainly residual hypersensitivity, either from pillar pain or from the nerve waking up in someone who has unrecoverable nerve who you've released, and then things such as reflex dystrophy. Well, perineural fibrosis, remember, all tissues except bone in the GI tract healed by scar. And so when you do your surgery, whichever surgery you do, remember that every time you handle the soft tissue, you are potentially creating a sticking point for the nerve or leaving some bleeding in the hematoma. All of those contribute. So how you do your surgery and that you handle the tissues gently is extremely important. Well, when you have that scar, when you have such scar, people have tried to optimize the environment by vein wraps initially, and now replaced by some type of conduit. And there's several that are out there. And finally, there are a number of flaps. We just heard from Jeff about a fat flap, but certainly there are other flaps which have been employed with equal success. So when you have someone who's had a carpal tunnel, I think you need to, as he said, sort of take a step back and go back to the initial, not only reviewing the records, but examine the patient and look for muscle atrophy and do your provocative tests. So make sure you look and do they have a Tinel sign? Where is that Tinel signs? Do they still have a Phalen's test? What is their vibration? I happen to like Sims-Weinstein monofilaments, which are a little more time consuming, but I think provide a fairly good, more sensitive look at the nerve. And again, I like a valid grip strength. If someone has a grip strength of 0, 0, 0, there are other factors going on other than a failed carpal tunnel release. You then can, if realistic, you can update the electric diagnostic studies. Now, usually you're going to wait 6 weeks at a minimum and usually longer. And furthermore, recall that even in successful carpal tunnel releases, the nerve test, depending on the damage that was present preoperatively, may in fact not normalize, even though the patient has a good result. So that's one of the fallacies of doing a nerve test. Certainly in the case that Jeff showed, where he went from a significant worsening, that would be there. But someone who's improved, say, from preoperative numbers, but still is having symptoms or has the same numbers, that doesn't mean that it was an incomplete release. You can use MRI or ultrasound as suggested. And that's becoming increasingly a diagnostic tool, allowing you to look at the pseudoneuroma of the nerve, whether you think the ligament was released. We certainly will do, in some cases, one or both of those, but I don't think that they're as accurate as we would like them, and I think there's a lot of operator judgment involved overall. Sometimes it can be useful to re-examine and re-inject the carpal tunnel and see if you get a positive response. If they have a positive response and say, I felt much better, and it's an extended response for 6 weeks, that suggests that they're, by taking down the swelling in the canal, that you can improve the situation. That's a good thing. Someone who says the shot was the worst thing that ever happened and made me worse, I would again raise my antenna that maybe this is not a case I want to take on surgically. Well, incomplete release. We always talk about it, and it certainly occurs. These are people you do a carpal tunnel release, and they really got no improvement. Essentially, not worse, they just didn't get any better, and you've examined everything else and they're normal, then you can begin to assume that they had an incomplete release. What I would caution people on, again, as someone who's in a referral practice, is I can't tell you how many times we get our partners, our colleagues in trouble by saying and that they did a surgery and it's an incomplete release. It's very hard, I think, to absolutely make that determination in many cases because the ligament reconstitutes itself, and a reconstituted ligament can be difficult to prove. But if you think you have an incomplete release, then all you need to do is re-release it. If I'm asked, was it an incomplete release, and I'm worried about it, I will actually send a biopsy of the carpal tunnel to see if they, in fact, the area that I thought was incomplete was in fact full of fibrosis and just reorganized. So I think that can help. And so here we have a case of someone who had a mini carpal tunnel release, a 54-year-old lady, 6 months ago, a little bit of improvement, but far from complete release, still having some night pain, positive phalans, positive Tenels, some weak abduction. You're going to repeat the nerve test, consider re-exploring it because it's a mini release, re-explore it because they never had resolution, or do a cortisone injection. Again, I certainly, as I said, would repeat the nerve test. I don't automatically assume because it was a mini, it was an incomplete release. I do worry if they had no resolution of any of their symptoms, but no worse. And I will sometimes, as mentioned, use a cortisone injection. And so here we have that patient re-explored. And one could argue, as we release this, that the proximal 3/4 or 3 to 4 millimeters of the transverse carpal ligament had been unreleased. We biopsied that tissue and it confirmed normal appearing ligament, where in another part that we thought was released, it showed amorphous scar tissue. So in this case, I think we could honestly say, yes, it was an incomplete release. Another somewhat unusual case is this is a patient who had an endoscopic carpal tunnel release with no improvement in their symptoms. They actually had an ultrasound done by the doctor who did the release, and he said the ligament is fully released. Patient's symptoms persisted. Well, in fact, he had done a complete release, but what he missed was there was an abnormal leaf of the palmaris longus tendon, which was extending across the canal and acting as a persistent band. So he'd released it endoscopically, but somehow had missed this abnormal slip of the palmaris longus. Once that was released and removed, the patient had complete resolution of their symptoms. How about someone who you release the nerve for a second time and see a fair amount of scar around the nerve, but once you do a scar release, basically the nerve looks pretty good. And so here we see a patient taking off some of this epidural scar through an extended approach, you will note, so that we start proximal or at the level of the takeoff, 5.5 centimeters of the palmar cutaneous nerve main branch, to also look at that. and then to free up the nerve. Once freed, however, no significant pseudoneuroma of the nerve, no significant scarring, and essentially doing a complete release helped this patient, which it did. What if you're faced now with significant perineural scarring? And here's where vein wraps became popularized by a number of authors. We used to use allograft veins. You certainly can get a vein from the same arm. I wouldn't go down to the leg necessarily to get a saphenous, but there have been a number of reports by Dean Soterianos and others showing that this was efficacious in the scarred nerve redo. Nowadays, obviously, it's conduits and wraps, and there are 4 or 5 brands out there. The concept is that you're sort of re-insulating the nerve, allowing, as the nerve regenerates, for those axons that escape the nerve to be sort of enclosed to protect some of the fibrosis. One of the problems with wraps and with much of nerve work is it's very subjective. We don't have an X-ray that says the fracture is healed and it's well aligned, etc. It becomes very judgmental. The patient's symptoms are all in all subjective. Obviously, if the muscle isn't working, that's less subjective. But by and large, how much tingling, how much night pain, how much ongoing symptoms they have or symptoms that persist are somewhat subjective. And so we use a nerve wrap and we tell the patient, yes, we've cleaned off the scar and we kind of isolate the nerve. So hopefully this will help. And in many patients it does. I'm not so sure that the wrap is the be all and end all. But here you see basically a nerve that was released here through a transpalmar incision. There was a fair amount of point scarring of the nerve, and putting a wrap around it after you've freed it up makes the surgeon feel better, hopefully the patient feel better. If there is extensive scar, then as Jeff alluded to, I think the hypothenar fat flap is an excellent flap in many patients. And you mobilize it as he showed so beautifully, and protecting the nerve by allowing improved gliding of the nerve. And I think many symptoms are adherence of the nerve, not because of pressure, but because the nerve is no longer gliding. It's adherent to the scar of the reconstituted ligament or the surrounding tendons. And a fat flap like this can enhance gliding, possibly give some improved nerve regeneration. He showed how to do it in a very standard, excellent fashion. And Jim Strickland really reported on a large series of revisions, 60 patients, as you can see, and showed significant improvement, about 90%. Chris Mathelin, who really designed the procedure, had excellent results, and about 94%. Other series have been a little bit less enthusiastic, but all show more patients improve than not. One of my problems with this is that some patients have enough scarring that mobilizing that fat pad can actually sometimes cause problems with Guillaume's canal, which you have to decompress in many of these patients to kind of get it mobilized enough, particularly if there's a fair amount of scarring. But I think it certainly has a role, and it's probably one of the first lines of altering the tissues surrounding the nerve to provide an optimum environment for the nerve. If for some reason you don't want to use a hyperthenar flap, our European colleagues have talked about using the tenosynovial flap. So here, after you've mobilized the nerve, you raise up the tenosynovium, as you can see in this picture, raised up and reflected radially. Now, once you've elevated it, you then place it around the nerve to hopefully provide a sense of gliding. Most of the literature is anecdotal about this. Again, it's tissue that's right there that doesn't require mobilization of Guillaume's canal. And in those few cases in which, for one reason or another, fellowship teaching, I felt that it was right there and a good thing to do, or a failed fat flap, which we've used it in, I think this has a limited but definite role. Finally, the use of a vascularized muscle flap, and we have adjacent to our scarred nerve a number of muscles depending where along it is, whether it's distal in the distal half of the canal or whether it's proximal. So we have lumbricals, we have the abductor digiti minimi, which are easy to mobilize on their vascular pedicles. We have proximally the pronator quadratus. And proximally, we have the flexor digitorum sublimis muscle. So what one does is usually the ring finger through a somewhat extended incision, one harvests the portion of the flexor digitorum sublimis muscle, leaving its distal portion still attached to the ring finger sublimis tendon. You let down the tourniquet to make sure it's bleeding, and then you can use this to wrap around the nerve, much as we see in this patient. We did a study at 2 years looking at 14 patients who had this done, and on an MRI follow-up showed that the muscle flap remained in place and was identifiable on MRI and subsequently on ultrasound in several of those patients, all of whom had significant improvements. And most of these were patients who were on their third and final try. So it's not my first go-to, but it's certainly one of my go-tos. And it does allow you to kind of wrap and enclose the nerve. You want to make sure that movement of the fingers doesn't put too much tension on the flap. We do let the tourniquet down to make sure we're getting good bleeding, but not excessive bleeding. So here we have a 68-year-old lawyer, advanced carpal tunnel, EMG, non-recordable, significant motor delay, thenar atrophy, present a number of years. Had a mini carpal tunnel release. Again, no particular issues with that, but not improved whatsoever. And so the question was, he was now 9 months, I believe, had a workup. He's 68. He does have some cervical root changes, but more in the C7 than in the C6, and not having any true root type radiculopathy symptoms. Had nerve gliding, as hopefully we'll hear about from Anne, and they told him nothing further could be done. He wasn't particularly happy with that. He felt he was worse. A repeat nerve test showed the sensory was still there. The motor was not worse, but unchanged. He did have negative findings in terms of the nerve, but had altered SIMS and altered vibration, had some response to an injection, and this is what was found. Very narrowed nerve with a large pseudoneuroma formation, and he was treated with an FDS muscle flap, wrapping the nerve after it had been freed. And at 1 year, his Levine scores had normalized, extremely satisfied, and had a relatively routine done on the opposite side. So I think you have to be familiar with each of these salvage techniques for the scarred nerve. Make sure your workup is thorough before you go in. We all, I don't care whether it's me or anyone, at the number of carpal tunnels that we do, or if you're a referral physician, as I am, the number of patients you're going to see who've had what we otherwise consider a simple routine case, who have either a complication or an unfavorable outcome. And it happens to us all. Sometimes there are factors that we should have paid better attention to, but many times it's the luck of the draw. And so you have to realize that all surgery is somewhat an imperfect science. and that no matter what you do, sometimes what you do won't work, and all you can ask of yourself and others that you do the best that you can do. And so happy results to all, and I'll stop now and turn it over to my co-panelists.
Great. Well, thank you, Lee. That was wonderful. Thank you for doing that. We do have a couple questions. I think we'll try to answer them later. So we'll go from Lee's talk to Kate Hinchcliff's talk on ulnar nerve compression at the elbow.
Hi, everyone. Thanks so much for being here, and thank you to AO for inviting me to speak as the faculty for this nerve compression seminar. I'm going to speak about revision surgery for failed ulnar nerve decompression. So I'll start with a quick case presentation. I'll go over when I perform my indications for performing a cubital tunnel revision, what different types of surgeries are that you can do for revision surgery, some adjunctive procedures that occasionally I will add to the suite of surgeries, and then sort of my little algorithm at the end. So this is a busy slide. I apologize. It's a classic San Diego patient, a 31-year-old police officer who had a gunshot wound to his ulnar nerve up at the sort of mid-humeral level, had a, I think, neuroma in continuity that was grafted by an outside surgeon with some improvement, but not like tons of improvement, and then sent to me for what else could be done. And evaluating him in clinic, he did have a symptomatic elbow, I'll harp on that again, with a Tinel sensitivity and some sort of frank subluxation. EMG was sort of as expected, some continuity, but pretty severe ulnar nerve injury, which you would never be able to distinguish really well from a carpal tunnel since the injury was above, or rather a cubital tunnel. And then ultrasound just to back up the subluxation finding. So this is someone that I would go back for revision surgery. I should point out that he did have a cubital tunnel release with his first procedure. Going in for a revision, I will perform a transmuscular if it was an in situ decompression to start with. I think very important points here. One, make sure you have a complete release of all the anatomic structures, so medial muscular septum, Osborne's, FCU fascia, FDS. One thing that this picture doesn't show well, so I was a little embarrassed, but it was the picture I had of the case, was that I do think it's very important to watch out for this flexor pronator mass edge. So it is released here, but you can see that like this nerve is still taking a little curve. And I think like the way you know you have everything released is that the nerve lies perfectly straight. And so it doesn't show that well in this picture, but I do think that's the important point. And then of course, preserving the MABC branches, because if you give them another issue, no one will be happy. So indications for revision surgery, and this is a broader term, I think, than Dr. Lawton, who was talking about failed cubital tunnel. So revisions can be recurrence, they can be failures. This is, I think, a little more broad just for the vernacular. I think symptomatic at the elbow, particularly symptomatic subluxation, is probably the most common one that I see. Someone who got better and then worse, or recurrence, no EMG improvement, or more likely EMG worsening in someone who would be reasonable to expect an improvement. Similar to sort of the themes on carpal tunnel, I would be less likely to revise in the setting of a neuropathy or some other double crush picture like a radiculopathy or a brachial plexopathy, and then less likely to revise if I thought it was a long shot to make anything better. Although I will say those patients are more likely to get a primary transposition for me because I want to feel that I've done everything in the first case. And then, of course, to Dr. Osterman's point, making sure that the diagnosis was correct, that it wasn't a missed TOS, Guillem's canal, or some other pathology. So I think these are really important numbers to quote to your patients. So this is just a nice review article people can have in their library. So whenever I'm entertaining a revision, ulnar nerve release of the elbow, I do make sure to tell patients that that is expected that there are some persistent symptoms in cubital tunnel release. So about a quarter of people will have some kind of persistent symptom, particularly if they had severe ulnar neuropathy to start with. And that a failure rate for a primary is about a little under 10%. So it does happen. And to the other panelists' point, it doesn't mean that whoever did the other surgery was a bad surgeon or did anything wrong. It just can happen sometimes. And then this is the sort of the number that I really make sure I tell people is that there have been some studies that show that good or better, so like a good or excellent outcome versus a fair or poor outcome occurs in about half the patients. So, you know, good outcomes half the time, but half the people fair to poor. And so you can talk 50% is a nice number because you can talk about it like a coin flip. Some studies do quote better than that, but I think if you're entertaining a revision, don't overpromise and underdeliver. Do the opposite. So what revision surgery to perform? This was an editor's choice from this year, which I liked because it supported what I usually do. It was a meta-analysis comparing pre- and postoperative symptoms between patients who had a submuscular transposition, a subcutaneous, and a neurolysis. It was a good, 20 studies. Obviously, meta-analysis can be a little bit fraught, but higher level evidence, of course, than retrospective. This study showed that subcutaneous transposition as a revision modality is effective, but that submuscular showed better improvement in sensory and motor deficits, and that neurolysis was good for pain sensory deficits, but not for motor weakness. I thought I'd point this out as well. This is not a surgery that I have done yet, but I heard about it at AHS, and I thought it was interesting. It is a sort of like everything's old is new again, new-ish kid on the block is the idea of an adipofascial flap with or without an anterior transposition. Dr. Matani, I think, was talking about it. It's based on perforators of the brachial artery, sort of similar concept to this hypothenar that Dr. Lawton talked about so excellently, with the benefits of wrapping in fat to reduce adherence, scarring, and make a nice sort of glide plane for the nerve and for hopefully vascular ingrowth. This is, again, not that well published, but I thought it was kind of an attractive idea that I might pull out at some point. Sort of unlike carpal tunnel, I think there are some sort of adjunctive procedures that I think about for cubital tunnel. The top one, I guess, for recalcitrant carpal tunnel as well, that is new and not particularly well published yet, but very interesting, and I think we're going to hear about more and more in the next sort of 5 years, is the idea of intraoperative electrical stim. Amy Moore is doing a trial on this right now with the checkpoint. But it has some data in animals showing improved regeneration of nerves through central upregulation of growth factors that are associated with neurons, and some small clinical studies backing it up. So if I'm doing a revision cubital tunnel or a primary cubital tunnel with severe EMG findings, then I have started adding this modality, and I'm going to just see how it goes. I don't think it adds more morbidity, and I'll be interested to see. Guillen's canal release, certainly if it's a recurrence, and there's any evidence of all of double crush, I'm pretty quick to add that, particularly if I'm doing a carpal tunnel at the same time. And then this, I think it's a super controversial procedure, but similar to like most things, hype is high and then settles out. But AIN to ulnar motor side-to-side nerve transfer is something I'll consider in cases of intrinsic atrophy if it has been a short period of time since onset of symptoms. So my surgical algorithm for recurrent cubital tunnel is first choice revision for in situ is a wide transmuscular anterior transposition. I had I will do a subcutaneous transposition. I think it's okay. The reason I'm more likely to do a transmuscular is I feel like the sub-Qs have a little more sensitivity, particularly in really active people who are like weightlifting a lot and hyperextending their elbows. I might consider that adipopassual flap in the future. I thought that was interesting. And then I'll do a full submuscular, so taking down the flexor pronator mass completely and then really putting the nerve underneath in a secondary revision for a previously anterior transposed nerve, or a case where I'm really never ever want to be back in the elbow and want to feel like everything was done at this one procedure. I think that Anne will talk more about this, which I'm excited to hear her talk, but post-op care I think is really important. So I do not immobilize any of these patients in plaster. For me, I'll do a bulky Jones for 7 days and then remove and do an ACE wrap compression to avoid hematoma seroma and get them into OT early. I think any sort of short-term immobilization and some kind of compression is good, but I think getting the nerve gliding quickly is really important for the elbow. And then I have started adding brief electrical stimulation. Please forgive me for adding something that I have no long-term studies on yet. And then, like I said, if they're young, under 50, and they've had symptoms like maybe under 12 months, but certainly under 6, with intrinsic atrophy, I will add that endoside nerve transfer. And I have seen specifically in a young patient with short-term symptoms that when I've added this, I have gotten motor recovery ahead of sensory recovery, which suggests that it was probably doing something. I have tried adding it in older patients or longer-term patients, and it has been a total fail for me. So I think it's a very specific population that benefits from this transfer. And then Guillain's, if there's EMG evidence. If I'm going to do this AIN, then you have to do a Guillain's anyway, so you'll add it in, or if it's a concurrent carpal tunnel. So this is just my algorithm. I look forward to hearing, if we have time at the end, from our moderator and Sage about their thoughts. Thank you.
Excellent. Well, thanks, Kate. That was great. And then next, Anne's going to talk with us, and Anne Porretto-Loehrke is going to share some pearls, not just on failures, but really on any compressive neuropathy from a therapy standpoint, and some things we can all learn from. So thanks, Anne.
So thank you so much for the invitation. I'm going to just talk a little bit learning objectives, looking to describe what does a neural mobilization program look like for patients following surgical release for carpal tunnel and cubital tunnel syndrome. And then I also want to talk about something called a graded motor imagery program, and that's really beneficial for patients that have persistent pain. A lot of these patients, as we've talked about, they've had symptoms ongoing for a while, and the acute pain model doesn't really work so well, that we have to look at it from a persistent pain standpoint, and there's some things that therapy can do to address that. One of my hobbies is I like to take pictures when I'm on vacation and put those as backdrops for slides. So this is in Homer, Alaska. Aren't these otters darling? They're so cute. So what is neural mobilization? So it's defined as interventions aimed at affecting the neural structures or surrounding tissue directly or indirectly through exercise or manual techniques. So what we're trying to do is improve the extraneural mobility, so the epineurium in relation to the surrounding soft tissue, as well as the intraneural mobility, the axonal flow and the intrafascicular motion. So what our goal is we want to get it moving, but we want to floss, or if we want to try to avoid tensioning by performing active assistive range of motion. So if we're going to provide a stretch at one end, we want to put it on slack on the other. So we talk about this like flossing your teeth. So neural flossing is underneath the umbrella of neural mobilization. So what do we find benefits from the neurophysiologic effects of neural mobilization? It can induce hypoalgesia, short lasting. It can also contribute to dispersion of intraneural edema. Animal studies have shown that neural mobilization may also induce an anti-inflammatory effect, not only at the site that you're focused on, but also at the dorsal root ganglion and some of the higher pain centers. So Zhu found performing neural mobilization that there was a reduction in mechanical allodynia, so that painful response to light touch in rats with type 1 diabetes. And what the mechanism they suggested was that it decreases the concentration of those pro-inflammatory cytokines, the tumor necrosis factor and the interleukin-1 beta, so that decreased their painful sensitivity. And then also in the rat model found that neural mobilization promoted nerve regeneration by increasing that nerve growth factor, and that was after a sciatic nerve injury. So what we want to do is we want to avoid doing too much too fast. So we want to instruct patients that they don't want to have any of that protective reflexive muscle guarding. They don't want to have an onset of their paresthesias, and they don't want pain. So we want to have a gentle, mild pulling. And I always tell patients when you do this, you want to smile when you do this. You want to be happy. So what we look at is we want to place the nerve more on slack proximally with getting that scapular elevation and side bending, provided that they don't have any radicular symptoms, and you want to then move distally. So this is showing for the ulnar nerve. There is no studies at this point to show what is the optimal frequency and duration. I like to tell my patients 10 to 15 repetitions 3 times a day, but so far to date, we don't have a study to say like this is the ideal. This was a systematic review that looked at 13 studies on the effectiveness of nerve gliding for carpal tunnel and found that the majority of the studies, the patients improved with their pain. They had a reduction in that pressure pain threshold, so that improved as well, and that this combined with other things would be helpful for accelerating their recovery. So when we think about median nerve flossing for carpal tunnel, we can do a longitudinal with looking at the index and middle fingers with flexion and extension, as well as improving that transverse direction of that nerve moving with performing thumb retroposition. So this just showing here for the median nerve, we have the thumb just relaxed for this first one. Index and middle fingers are brought into extension as we place it on slack proximally and then coming back. And if patients, ideally you want them to do more of the seesaw maneuver, but if they just can't get it coordination-wise, just have them on slack here then as they move distally. But you try your best to try to get them to do it together. And then 2, this is just showing, I don't have a video of this, but showing gentle thumb retroposition and opposition to help facilitate that transverse mobility of the nerve. Again, making sure it's pain-free, that they feel only a mild pull. And this was a cadaver study, which I thought was really important to share. What they looked at is traditional nerve gliding techniques, and they decided to do finger A, B, and A deduction, and they wanted to see was there a difference, and found that the conventional nerve gliding had a substantially less amount of glide through the carpal canal, so only 6.6 millimeters. With finger A, B, and A deduction, and they did this at 90 degrees of shoulder abduction and 90 degrees of elbow flexion, that they found via cadaver 13.8 millimeters of nerve glide. So that's something I think that is valuable to have our patients starting to do early on. And you're also getting some mobilization of the ulnar nerve as well through Guillen's canal. I also think it's important to address the whole nerve pathway, so they can start doing some brachial plexus flossing here. And then this is a shoulder clock, so we get some engagement of the upper thoracic spine with rotation. So their hand is the clock, and the goal is to keep their hand in that same plane. So they're getting not only neural mobility, but also getting that upper thoracic motion and scapular retraction to help open up the space proximally. So looking at graded motor imagery, so we think about the persistent pain or chronic pain patient. Sometimes they have releases, but they still have that hypersensitivity. And when we look at the whole mechanism of central sensitization, this is again very different from acute pain. So we see changes in the spinal cord where we see this onslaught of the nociceptive input that's happened over a longer period of time affects the dorsal root ganglion. And then we see, instead of just synapsing on one lamina in the dorsal horn of the spinal cord, now it's going to synapse into multiple. So what we get is a sensitivity of the whole nerve. And there's been some studies. This is just one example. This is a study that was done on patients with persistent carpal tunnel syndrome. They looked at the pressure pain thresholds And they compared those with carpal tunnel and age-matched controls without, and found those with the more persistent or chronic carpal tunnel syndrome had more widespread pressure pain sensitivity, more increased pain, and that was throughout the body. And they attributed that more to this central sensitization. Excuse me. So one thing that we can do as therapists is something called the graded motor imagery program. And what this is a step-by-step program to help facilitate a reduction in that hypersensitivity or central sensitization. Excuse me. The first step is doing what's called laterality training. So they're basically identifying right and left as fast as they can. That warms up the brain. They perform that 10 minutes each waking hour. So it's pretty intense. I tell them, like, this is your new full-time job. They do that for 2 weeks. Then they do imagine movement. So I take those same cards, if it's, say, their right hand, and they picture in their mind their hand doing those movements. So it's not that they're actually physically moving. They do this also in addition to doing neural flossing techniques. But then they also then follow up with the 2 weeks of mirror therapy. And what the mirror therapy looks like is they take their involved side, they hide it in a box behind the mirror, and their brain, their eyes are watching the reflection of their uninvolved hand doing the motions that may have been painful before. And this can be really powerful. It's like it gives the brain permission to be able to move. We had an example of a guy with an old injury to his finger that when this first came out, he was significantly stiff, couldn't move it. We gave him the mirror box to take home, and he worked on it over the weekend and came back with full motion. So there is that brain component that this program gets to. So what graded motor imagery does, it interrupts that abnormal sensory loop that they expect of pain with their motor output. So the laterality training warms up that primary motor cortex, then the imagined movements gets it closer to movement, and then it's exposed eventually to movement with the mirror box. So it facilitates that more normal movement pattern. So with repeat carpal tunnel or cubital tunnel release, consider referral to hand therapy for the following: for neuromobilization techniques, starting to get things moving faster and sooner. And then if they have persistent or chronic pain, consider ordering graded motor imagery, because that can also be an adjunct. Thank you.
Thanks, Ann. That was great. And that was a way to really hammer home some themes that were talked about by myself, by Dr. Osterman, and Kate Hinchcliff in terms of, getting nerves moving. I thought that was great. Lee, I'd like to ask you a question. A couple came up and you sort of mentioned it in your series. So patient that comes to you, and it sounds like you have a number of these patients in your large series at the Philadelphia Hand Center, endoscopic carpal tunnel release. You are convinced it is in fact carpal tunnel syndrome and not more proximal compression. What is your thought process? Are you going to do an extended traditional carpal tunnel release? Are you going to offer them a repeat endoscopic carpal tunnel release? Are you going to make an intra-op decision about environmental change? How do you approach those?
Well, number one, the first is I got to believe that they need a re-release and that I can do it. Obviously, if I do a re-release, I usually, even though I do endoscopic carpal tunnel, I don't use an endoscopic technique. So I'm going to use some open technique. Usually it's going to be a transpalmar, not a mini. In rare instances, again, if it's a virgin and they're coming to me after just one attempt, it probably would not be extended. Generally, if the nerve looks pristine and I think it's an incomplete release, I will release it. And if the nerve looks good, I will stop at that point. If I have any question, again, I don't like to dictate the nerve was incompletely released without proof. So it depends a little bit if the patient comes in because the workers' compensation patient, they already have a lawyer involved who's, sitting there. They sent my patient back to work. They never released it. Now that poor other fellow who did the incomplete release is in trouble. I like to confirm. I always take a photograph in a re-release case universally to show what I found, good or bad. And I often say I couldn't tell. Certainly, it had reconstituted, and I try to be as non-committal about that per se, as opposed to a nerve that's cut and unrecognized, where then I'm very pro-patient that the nerve wasn't recognized. I didn't make a decision. Game time is whether I'm going to use. In the scenario you're describing, the most I'd likely use would be some type of wrap rather than a fat flap or some of the more elaborate coverage, just because it's a virgin case. There hopefully wouldn't be that much scarring.
Okay, great. Thanks. Kate, your thoughts. I'm interested to hear in the future about the mini stem. I've heard that from a few people. Amy has talked about it. Interested to see if that makes a difference. Any environmental improvements in terms of conduits or vein wraps in your thoughts, or is it just a complete decompression, submuscular or intramuscular, and making sure it's got a straight path?
Yeah, I am nothing against conduits, but I don't think that they're, I think a complete release and then early gliding should get the nerve moving. And so what is a conduit really going to add to that? I struggle to think of any cases where I've added a conduit. I think if I'm that worried about things scarring in, I'm going to be wrapping the nerve in fat for like doing a hypothenar or like really changing nerve position for a ulnar nerve.
Excellent. All right. Well, I want to thank everyone. Great talks as always. Lee Osterman, Kate Hinchcliff, and Porretto-Loehrke, and then our support from AO, Mackenzie, and Abby. So thanks, everyone. Good night.
Bye.
Have a good night. Thank you.